Welcome everybody to this presentation following an extended child safeguarding practice review regarding 3 young people from the Trafford area. I'm first of all going to go through a little bit about the 3 young people so you get a sense of the issues that might have presented for them as they were growing up and at the time of the sort of serious incidents. Teddy, he was a 17-year-old at the time that he sadly died. He'd identified as transgender. And as with all 3 of these young people, he'd been engaged with child adolescent mental health services and had some general mental health issues for a number of years. He'd had some quite important experiences throughout his younger years, and he'd experienced loss in the way of a sibling and bullying throughout his school years. He was under the care of the Gender Identity Development Service from 2016 and had some engagement with them. He often expressed some thoughts of self-harm and suicide, and he was reported as a victim of some hate crime as well, which seemed to relate to his gender identity issues. He was also diagnosed with ADHD and this caused him a number of issues, and he received some medication to assist him with that. He also had some indicators that were suggesting that he might have autism, but actually had never had a formal diagnosis of that. In terms of his family life, he had 2 loving parents, but there was quite a disruptive caregiving with one parent, with parents separating, and then particularly his father not being available to him sort of in the evenings as well. And there'd been parental domestic abuse and also some parental alcohol abuse as well. He had 2 younger siblings and they had been assaulted by mother's partner and had been deemed to have been children in need. And certainly Teddy was had sort of experienced all that brought with it. He took an overdose and was diagnosed with anxiety and depression. Teddy reported an abusive relationship and sexual abuse by multiple people. He did not find it easy to engage in therapeutic support, and following discharge, Teddy discussed cannabis and alcohol use and having visual and auditory hallucinations, and that resulted in an admission to hospital under Section 2 of the Mental Health Act. A diagnosis of emotionally unstable personality disorder was being considered, but due to his age, he was deemed sort of too young to make a definitive around that. Over a period of time, ligaturing and self-harm escalated, and that seemed to escalate more after home leave, and he was placed on Section 5 of the Mental Health Act. Differences in management of risk between children's social care and the general adolescent unit became apparent at that time, and specialist CAMS believed that Teddy's inpatient status was exacerbating his self-harm, whereas children's social care and mum were concerned about how they might be able to manage his risk to self and risk to siblings at home and in the community. So there seemed to be a sort of divide really in professionals' opinions at that time. Teddy returned to the ward following an episode of home leave and self-ligatured on 4 occasions, and on that 4th occasion he was found unconscious. He was resuscitated, but sadly he died 5 days later. Okay, in terms of Wilbur, the 2nd young person, he was nearly 16 when he took a significant overdose. Wilbur is of Eastern Asian origin and identifies as a transgender male. He also experienced some disruptive caregiving. He has 3 siblings, 2 of whom were younger, and was known again to CAMS and was known to have been physically abused by his parents. He became a care experiences child in September of 2018 alongside his two younger siblings. He had anxiety and sleep issues, and suicidal thoughts were reported. He had quite a difficult relationship with his parents, and actually his mum made significant efforts to try and contact him whilst he was in care, and he found this extremely unsettling. He was keen to access some emotional support. It was very focused on gender transition and was on the standard waiting list, which in November of 2020 stood at 26 months. But due to COVID, we know that that is likely to increase. Will was an extremely bright young person, and academic success was very important to him. He was had very high expectations of himself, and his self-worth and self-esteem were really kind of wrapped up in his academic success. He expressed a desire to end his life, and in the presence of the rapid response team took a significant overdose, which proved near fatal. He required resuscitation, ventilation, and hospitalisation in the intensive care unit. And the final of our three young people is Peter. He was 17 when he attempted to take his own life. He was born in Western Asia and again had disruptive caregiving. He was placed in a SOS children's village as a baby until he was 6 years old. And from that time, he moved backwards and forwards between Western Asia and the UK. Peter experienced disruptive caregiving, multiple incidents of violence and torture whilst he was in Western Asia. But he also had treatment for cancer and experienced some bullying at school, and that really sort of centered around cancer treatment and his appearance during that time. He's another young person who's very intelligent and a sensitive young man. English was a second language for Peter, which was suggested could be acting as a language barrier, although to speak to him, you wouldn't necessarily be able to pick that up. He has lots of underlying anxieties. Peter was accommodated by the local authority under Section 20 and lived in a local authority registered children's home. His father, stepmother and a sister lived locally. And mother at that time lived in Western Asia. His father exhibited some very kind of controlling behaviours. In August of 2020, he was reporting suicidal thoughts, ideation and attempts, and he had attempted ligatures and absconded after being admitted to a medical assessment ward. He reacted badly to the environment. He refused the admission to an adult bed and remained on a trolley in a treatment room for 5 days, whilst professional disagreements were resolved regarding his legal status as a cared for child and his mental health presentation and needs. After 5 days, he was admitted for a period to the general adolescent unit, and mental health services were involved. In November of 2020, he was referred to CAMHS by his social worker with low mood and poor sleep and history of trauma and self-harm. He was assessed by the Improving Access to Psychological Therapy team and refused to agree to a safety plan, as at that point he did not care. He was referred to the home-based treatment team, who agreed to offer an assessment. But Peter continued to express suicidal ideation, and following further attempts to take his life, he was eventually admitted to the general adolescent unit after a 5-day stay in an adult setting at Salford Royal. So I was asked to undertake this thematic review because, as you can see from my descriptions of the three young people and what they'd experienced, that there was quite a lot of sort of similarities there, although I do recognise that they don't completely align. But what we used was the information that had been provided via the rapid review process, and we brought all of that information together into integrated chronologies for the 3 young people. I spent some time analysing that chronology, and then we held a practitioners event and a managers event. And as you can see, there were 15 people at the practitioners event and 19 at the managers. I was very, very privileged to be able to speak to either the family members and to 2 of the subjects of the review, and their contribution was enormously helpful in terms of giving me an understanding from their perspective of the kind of interactions that they'd had with practitioners and of the services that they had, and their experiences of those. And we had a panel. That panel was made up of senior members from each of the organisations that were involved, and obviously they had an opportunity both to review and make comment, and also to challenge me about the content of the report. So I'm just going to go through with you sort of the key lines of inquiry. So this was what I was asked to review as part of this review process. And the first bit was around sort of resources and configuration of services for young people who sort of self-harm. The second one was actually looking at the legislative framework for working with 16 to 18-year-olds, and actually whether that was helping practitioners in their practice or whether there was sort of any difficulties around that. Third one was looking at multi-agency arrangements for keeping young people 16 to 18 safe. I was also tasked with looking at trauma-informed practice, looking at whether there was evidence of that and whether there was, whether there was further work that was required. I was also tasked to look at information sharing, who knew what at what time, and whether any changes in information sharing were kind of required, or what the barriers might be to sharing information. And then I was asked to look at the impact of COVID-19 on the services that were being delivered to the subjects from March of 2020, as the suspicion was that that may well have affected the ways that sort of services were operating and the kind of contact that these young people were having with practitioners throughout that period. So I'm going to go forward now and sort of talk to you about the learning from the review, and the 9 recommendations that have actually come out of this review, which are now for the board and partners to really take action upon. The first area was around these resources and the configuration of services, and it will not be a surprise, I don't think, to any of you that the finding was really around that lack of provision for young people, and also that sort of 16, 17-year-olds were being admitted to adult wards in acute settings, as both of those issues really are kind of national issues. But it's important for us to kind of remember, Standard 4 says that all young people should have access to age-appropriate services which are responsive to their specific needs as they grow into adulthood. And actually just a number, an age, is kind of arbitrary, and really we need to be sort of tailoring the way that we're working, which actually meets the needs of the individual young people. There was a real gap for young people who didn't meet the criteria for Tier 4 mental health services provision, or those who would not significantly benefit from admission. And this really relates to the fact that actually some young people's self-harm behaviours will actually increase during an admission. And so actually, but there was nothing really within the community that was going to address and was set up in a way that kind of intensive input could be given, really. So where a child or young person did not meet the criteria for detention under the Mental Health Act, or was not suitable or agreeable to an informal admission, and where a return home was not a safe option, the local authority have a duty to find a suitable alternative placement. And both health and social care really need to work together to commission appropriate placements. At the moment, those placements are not there. And I think this is why there became a little bit of a tussle between children's social care and the health organisations about, you know, whose responsibility that was, and actually, you know, how they were going to get that kind of provision available for young people. So the recommendation here is really for health and social care commissioners really to review the current offer that they've got going for 16, 17-year-olds who are exhibiting their distress through self-harm, and really establish the level of need for mental health and therapeutic services to ensure its commissioning arrangements are robust. This is obviously in the backdrop of the fact that, you know, that there is limited money around at the moment. So whilst this is a recommendation, I'm not underestimating the issues that might present to commissioners to work towards that. But it really is quite a significant gap for this particular group, and unfortunately it is a group of young people which seems to be getting larger as time goes on. So the further recommendation around there is mental health services to work with children's social care to develop a process that identifies the need for a therapeutic placement, ensures this is communicated to children's social care at the earliest opportunity. And I think that there is a need really for very close partnership working between the two from a very early point. Otherwise, we do get into this situation of one not being happy with the other, and that can be quite destructive and unhelpful. Currently, young people displaying behaviours suggested of emotionally unstable personality disorder, where there's a reluctance to diagnose on the part of the clinician and not receiving the same services as those whose clinicians are more agreeable to making an early diagnosis. Certainly the guidance there is for clinicians that suggests you know, that an earlier diagnosis can be made in certain circumstances, but there are some clinicians who decide that that they're not happy to make that definitive diagnosis until the young person has reached 18 because of developing personality throughout that time. But actually what we need to make sure is that the sort of services that would be available to a group that have actually got that definitive diagnosis are the same as those where it is suspected as well. So my recommendation here was around a real need to review the personality disorder pathway to ensure that kind of consistent approach and access to services for people displaying behaviours suggestive of emotionally unstable personality disorder. So the second area that I looked at, the legislative framework, really just the conclusion was actually that the framework can be very confusing, and real need to kind of consider each individual in context of their age, their maturity, mental capacity at each contact, and requests for legal advice in such circumstances should be a priority. What we're seeing was that actually there was a sort of almost a delay really, or a late coming to the table of asking for sort of legal advice. Records really need to clearly identify who has parental responsibility and who are the decision makers, so that when a young person is of an age to make their own decisions, temporarily lacks mental capacity to do so for any reason, the correct permissions can be obtained. And for one of our young people, this became a real problem, as it wasn't clear whether parental responsibility still remained with their biological parents or whether that had been taken on by the local authority. So recommendation really there was around services making sure that there's clear record of parental responsibility that's amended if a child or young person is placed on an interim or full care order or adopted. And that children's social care ensure a system is in place that leads to swift action to apply to the courts for an order if those with parental responsibility are deemed unsuitable to make decisions. So where parents have been found to be being abusive to the young person, they still have parental responsibility, but actually couldn't be relied on. It was felt they couldn't be relied on to make the right decisions for that young person. So really important to make use of the legislative frameworks that are available to us in those circumstances. In respect of multi-agency arrangements, the learning point here was really around when young people go into hospital, certainly into sort of mental health concerns. It's really that need to maintain high levels of engagement and support throughout that person's admission into hospital. What we tended to find was that actually the community staff at that time really handed over responsibility for the young person's care, rather than actually using that as a time where it almost doubling up of professional involvement, really. So imperative that they continue to have an understanding of the young person's condition and the likely position at point of discharge, because the one thing that we always know is that when a person's gone into hospital is that they will be returning out into the community, and it's an opportunity really to get one step ahead by being involved throughout that period of time. And there was a very sort of specific learning point around making sure that children's social care were fulfilling their responsibilities for under sort of Section 85 for care of young people sort of in hospital. So recommendations there were really that mental health inpatient services and children's social care to review their discharge planning processes and ensure multi-agency response to discharge planning that commences on admission. So right from the very beginning, be thinking about actually what is the likely scenario going to be at point of discharge, and kind of keeping that under review all of the time. And the other one was very specific to children's social care, and that was just around auditing their compliance with Section 85. Okay, so next key line of inquiry was looking at sort of response to children in crisis. And the learning that kind of came here was that actually recruitment and retention issues were impacting on the skill level of the workforce. So, you know, what you find is sort of a robust training program, but actually the churn and the turnover of staff was actually diluting the effectiveness of that. So this and less effective multi-agency working at times of crisis was having a negative impact on a young person's care. There was some confusion over roles, responsibility and accountability, and that coupled with some professional anxiety and a lack of knowledge as to how to work with such complex cases and differences in how services manage risk was reducing professionals' grip on cases at a time when multi-agency coordinated response was sort of essential, really. So there was actually a number of kind of factors that came together. And whenever you're dealing with sort of such complex cases, there always comes with it some anxiety. And when you bring together multiple professionals, it can be difficult for people to actually understand and work out who kind of taking a lead with these cases and what actually your role is within in working those cases. So it's really important to actually tease that out and make sure that that is kind of clear for each case that you're working with. Lack of resources to support young people who don't meet the threshold to be detained under the Mental Health Act, but actually are needing quite a high level of care that can't be met in the home or by community services. Coupled with a lack of joint funding was leading to some tension building up between mental health services and children's social care. And really it got into a situation where both were feeling it was the other's responsibility. And unfortunately, in the middle of that, you people who are maybe not getting the kind of support and care that they need throughout that period. So recommendation was really around actually recognizing the fact that you have got these kind of very complex cases coming through, and the need really to develop a complex case management process which actually really makes it clear to practitioners what their roles and responsibilities are, what the lines of accountability are in those cases, and really practitioners at the front line needs to be supported by commissioners and providers, really exploring the gap in provision and considering how best they can meet that kind of group of young people's sort of needs, really. Because actually, if practitioners who are involved have not got the services to actually support them and the young person to get better, then that's always going to be sort of problematic. So it is about thinking slightly out of the box, I think, and for this particular cohort of young people, and thinking about actually, is there something that needs to be developed that is a bit different from the normal services that everybody's familiar with. In terms of trauma-informed practice, these three young people had experienced multiple traumas, and it was really a joy for me to know that actually the practitioners who were involved with them understood that very well, in terms of they weren't unknown traumas. But it's actually then what happened in terms of, you know, how they were being sort of considered, and actually how you could evidence within plans of care that they were being sort of fully considered, and leading to some really clever sort of safety planning. So whilst plans are about now and the future, they must be placed in the context of those kind of past traumatic experiences for them to be fully effective. And another thematic review of adolescent suicide really talked about safety plan intervention, and that what was a best practice brief intervention that incorporated evidence-based suicide risk reduction strategies such as lethal means reduction, brief problem solving and coping skills, and increasing social support and identifying emergency contacts to use during a suicide crisis. And actually that review really kind of noted that in conducting the safety plan intervention, clinicians and patients collaborate, and they develop a sort of 6-step plan for staying safe. And though that 6-step plan includes identifying warning signs, looking at the individual's coping skills, people and places to go for distraction, people to contact for help, professionals to contact for help, and steps for means of safety. And it seems to be a really good kind of foundation that might be useful within Trafford and for Trafford's young people. So a recommendation there is really around promoting that trauma-informed practice and safety plan intervention through training, policies, procedures, assessment and care planning processes. In terms of information sharing, what I found was that there was a real need for applying information sharing guidance in order that information is shared appropriately when there are concerns regarding the safety of a child. There's that need for that real kind of consistent approach to sort of be developed and supported through multi-agency training and supervision. I think over time people have got a little bit confused about actually what they can and they cannot share, and certainly my experience is that actually if you were in a court of law, judges don't ever seem to criticize for what you did share, but they do ask questions about what you didn't share. So it's really important to actually think about the reason you're sharing that information, or the reason you're being asked to share that information. And if it relates to safeguarding that young person, that's justification for doing that. So yeah, need a consistent approach to be developed and supported through multi-agency training and supervision, and by ensuring the expertise of managers and named and designated professionals, and making sure that actually there is a sort of conduit for frontline practitioners to use that expertise that has been developed within your named and designated professionals. So where a young person with self-harm mental health issues is likely to access or be accessing their emergency care from an emergency department close to their home, but not within the local authority boundary, arrangements needed to be put in place to ensure that treating medics have immediate access to relevant information, including clinical and legal information. And I think one of the issues that you've got within Greater Manchester is actually the amount of choice that is given to young people and their families about where they go to for their care. And local authority boundaries do seem to make a real they provide difficulties, I guess, in terms of information sharing across. So whilst you might automatically know that somebody is on a child protection plan if they're accessing emergency department in the area that they live, that's not the same across boundaries. So it's really kind of thinking about actually, how that information can get to where it needs to be in a timely manner. So recommendation for Trafford is to think that through its training procedures, promote a culture of appropriate information sharing, ensure those in roles advising practitioners are clear regarding when and what can be shared for the purpose of safeguarding children and young people. I think the impact of COVID-19 has been enormous and for everyone, but actually in particular for the subjects of this review, either during admission to hospital in terms of contact with family, carers and practitioners, or because of the need to self-isolate. So there was an occasion where services couldn't be accessed because and support couldn't be accessed because of the need to self-isolate. And the issue around the mandate to discharge patients at the earliest opportunity certainly played a part with one of the young people within this review. And I recognise that this situation was unprecedented. And whilst it had a negative impact, this was somewhat unavoidable. Certainly in the early stages of the pandemic, services and practitioners sought to make sense of an ever-changing sort of landscape, really. It's important to recognise that points of admission are by their nature stressful, and as such every young person needs to be sorted by an appropriate adult. And whilst there's no doubt that COVID-19 has had an impact on the entire nation, and in the early stages brought confusion and change to services and practitioners' ways of operating, agencies seem to now have the infrastructure in place to help keep services running. And so on the back of that kind of finding, I didn't feel that there was a necessity to make a recommendation. When we do these reviews, as well as looking at areas where we think that there needs or could be improvements sort of made, or where boards and partners could be focusing their energies, we also try and pick up on those things that we noted as sort of good practice, because we don't want to lose that whilst focusing on things that we maybe want to sort of change, really. So what I found was that actually in general interagency working was pretty good. It was the barriers in terms of being able to have the sort of resources that might be necessary to support that is where things kind of got a bit stuck, really. There was some evidence of good information sharing, but the bit that I picked up is about sort of the consistency of that, and some people getting a little bit hooked up really on what the could share and couldn't share. There was some evidence of good collaborative working between children's social care and the police, which is really positive. And in Teddy's case, there was a good example of professional curiosity. All the children in that case were spoken to alone, and that's unusual for me to sort of see that in such a positive way within the reviews I do. The CAMS work that had been done was well documented, and there were some really good, robust conversations happening between Wilbur and his therapists. And the therapy was kind of providing strategies for him to be able to manage his life a little better. The review group noted that CAMS completed extensive work with Wilbur, and he was involved with decision making throughout those interventions. Different therapeutic interventions were offered, appointments were regular and consistent, and each contact showed some evidence of good care planning, risk assessment, and a real good focus on his goals. There was a really good narrative letter actually to Wilbur, the social worker and foster carer, upon his discharge from the service. And there was some good challenge at professional meetings, and risk was sort of being managed appropriately. It was noticed that when Peter became accommodated by Trafford Council, he was quickly engaged with professionals that could formulate plans with his input. Peter was very active in his own case planning. And during Peter's time in care, he was referred to and seen regularly by oncology. And the quality of his placement assessments was good. There was a real positive commitment from the staff within his residential setting. And there were two things that came out of the practitioners event, and that practitioners identified two resources that were having a real positive impact. And the first one was the Greater Manchester Mental Health Helpline. And that was viewed as a crucial resource for young people experiencing issues with their mental health. And the second one was the Manchester College, which was employing mental health first aiders and practitioners, and was providing some counselling as well. So some extra resources that are available for some of your young people, and could maybe be being used by others that are not currently using them. So some real nice, positive, good practice that was evident there. Okay.